Hello, everyone, and welcome to another episode of Rebelcast. My name is Will Smith, and today we have a very interesting article out of the Pediatric JAMA about something that is very applicable to all our practice as emergency medicine physicians. But before we do, I'd like to introduce my co-host, Dr. Marco Perpersi. Marco, go ahead and introduce yourself.
How's it going, folks? Nice to see everyone again. Nice to hear from you, Will. Marco Perpersi, Vice Chair APD at Vassar Hospital in Poughkeepsie, New York, and regular content creator and contributor to Rebel EM, Rebel Podcast, Rebelcast, Rebel Reflections. So we're doing it again.
Like I said in the beginning, my name is Will Smith, and I'm an intern year attending in Northern California. I dabble in Rebel EM, especially compared to Marco, but I'm also an EMRA ERCast podcasting fellow. Today, we are going to be talking about the P in pediatrics, short course versus long course antibiotic therapy for UTIs. Marco, why don't you give us a little bit of a background on this topic?
Yeah, this is actually one of my favorite topics. And I think a lot of the literature that we use to determine the treatment for various infectious conditions is based on just like dogma and anecdote and very, very old studies. There's been this shifting paradigm in the last couple of years, a lot of JAMA pediatric publications questioning whether we can use shorter courses of antibiotics. And there was a recent meta-analysis for pneumonia. There was a SCOUT CAP trial for pneumonia. And now here we have a SCOUT trial, which is looking at duration of UTI treatment for pediatrics and asking the question on whether or not we could perhaps shorten it.
The paper that we're going to be talking about is by Zautis, Shake, and Fisher et al., Short Course Therapy for Urinary Tract Infections in Children, the SCOUT randomized clinical trial. It was in JAMA Pediatrics 2023. Marco, what was the overall question that we were going after with this?
The investigators in this trial were asking in children 2 months to 10 years old who exhibit signs of clinical improvement after 5 days of antibiotic therapy. Is a short course of antibiotics, 5 days in length, the same or as effective as a standard course, 10 days in length, in preventing treatment failure and related outcomes?
Talk a little bit about how they went about answering this question.
This was a multi-center randomized, double-blind, placebo-controlled, non-inferiority trial. So as far as studies goes, this is pretty high quality. They recruited patients from primary care offices, emergency departments, and inpatient wards in 2 centers, one in Philadelphia and one in Pittsburgh.
Give us a summary of what exactly they looked at.
They were looking at potentially eligible children who were already being treated for UTI, and they had to have signs of clinical improvement, which means they couldn't be febrile. And they assessed these patients on days 2 to 5. After consent, the children were then randomized in a 1-to-1 fashion to either receive 5 additional days of a matching placebo or 5 more days of antibiotics. And they assessed these children for clinical outcomes in 2 in-person visits on days 11 to 14 and another follow-up visit on days 24 to 30.
As far as funding goes, this was funded through the National Institute of Allergy and Infectious Disease, and it was a registered trial at clinicaltrials.gov. Inclusion criteria. Talk about that a little bit, Marco.
They actually took basically all comers. They included all patients who were aged 2 months to 10 years old. They had to be diagnosed with UTI. And one caveat is these patients have to be treated with one of 5 different antibiotics. And it was Augmentin or amoxicillin clavulanate, ceftonir, cefixime, Keflex, or Bactrim, which is trimethoprim and sulfamethoxazole. Other than that, they had to be recruited from one of those locations we talked about, which are the primary care offices, the emergency departments, and inpatient wards. As far as exclusion criteria, the list is fairly lengthy on first glance, but I think essentially the gist what they were trying to do is they wanted to exclude any patient who had a high-risk urinary tract infection, like those patients who were likely to fail treatment because they were septic or they had some drug-resistant pathogen or they had some chronic medical condition, which is going to put them at higher risk for developing a serious bacterial infection.
The way that this study was carried out, the intervention group would receive 5 days of antibiotics, and then they would also receive 5 days of a matching placebo. The standard course would be patients that received 10 days of antibiotics. The primary outcome in this was defined as a UTI between day 6 and day 11 through 14. Can you talk a little bit about the study population in general that was initially screened?
Well, they screened more than 30,000 patients. I think it was 32,271 to be exact. But more specifically, when we look and we peel back the layers, they actually excluded more than 20,000 patients who were treated for UTI who actually had negative cultures. Another 5,000 patients or near 5,000 patients were excluded for quote unquote other reasons. 1,100 patients couldn't be reached. About 1,000 did not receive one of the initial accepted antibiotics. And there were various other reasons, but ultimately, they included almost 700 patients in the trial, 693. 348 were allocated to the standard course therapy, which is 10 days of antibiotics, and 345 were allocated to the short course therapy, which is 5 days of antibiotics and 5 days of placebo.
There's two big numbers that you talked about. Almost 32,000 were initially screened, but only about 700 went through the trial. Is that about right?
Yeah, I mean, I think we're going to into this a little bit more in the discussion, but herein lies the problem and the difficulty in diagnosing pediatric UTI. Just a lot of these patients are not ultimately going to have a urinary tract infection. Because of the way that they diagnosed urinary tract infection, it required a positive culture, and that's going to screen out a lot of these patients.
Let's talk a little bit about primary outcomes. The standard course, which again is the 10-day therapy, had a lower rate of treatment failure. It was around a 0.5% compared to the short course, which was just over 4%. The upper limit of the confidence interval of the absolute difference was about 5.5%, which exceeded the prescribed 5% margin. Treatment failure was not related to age, fever, prescribed antimicrobial therapy, or study site. And then I think maybe one of the highlights of the primary outcomes is the short course therapy did not prove to be statistically non inferior to standard course 10-day antibiotic therapy. As far as the secondary outcomes that came from this study, is the short course therapy was associated with the higher rates of asymptomatic bacteria and positive urine cultures at days 11 through 14. There was no significant difference observed in other secondary outcomes or adverse events. Why don't we talk about the strengths of this study?
This was an easy one. This is a really high quality study. As we mentioned, this is a double blind randomized placebo controlled trial, which essentially this is the gold standard for medical literature. They employed a non inferiority trial design, and non inferiority trial designs are used to assess whether a newer therapy, in this case, a shorter course of antibiotics, is non inferior to the standard therapy, in this case, 10 days of antibiotics. And these non inferiority trials make sense when this new therapy has the potential for something good, like fewer side effects, cost savings, and even potentially lessening the global health burden. The researchers also chose a very narrow non inferiority threshold of 5%. When you have this narrow margin, this narrow threshold, it makes it more difficult to prove. So, if something is truly non inferior or statistically non inferior based on a narrow threshold, you feel a little bit more confident in the robustness of the data. They actually use pretty strict criteria to diagnose urinary tract infection, which we mentioned earlier. They enrolled patients in multiple clinical centers and multiple environments, which increases generalizability because we're not just seeing these kids in the ER, we're seeing them in our outpatient settings, our urgent care. Some of them are even getting diagnosed in inpatient wards. The randomization was pretty good, and there were no major differences in baseline demographics. And that indicates that, again, randomization was sound and that the patients had a similar prognosis at the beginning of the trial. Importantly, the placebo had the same volume, had the same appearance, had the same flavor, the same consistency, and the same bottle as an actual study drug. And that decreases the probability that there's going to be unblinding or a loss of concealment of the study drug. Trial participants, their parents, investigators, and trial personnel, they were all blinded to treatment assignment. And the investigators analyzed patients in intention to treat analysis and per protocol analysis. And this actually really allows for a comprehensive assessment of the data and of the results. And lastly, loss to follow up was very low and similar in each group.
Let's talk about limitations. This study was only done in one country that can limit the generalizability. But on the other hand, it's a pretty diverse population. We pulled from clinics, we pulled from ERs, but in the long term, this was only one country. Another thing that we saw with this is UTI investigators include some signs and symptoms that were kind of non-specific and could also be attributed to something like a pylo. And typically, clinicians are going to treat that with a longer duration of antibiotics, which we're kind of trying to see if a shorter term is non-inferior. So sometimes that can also limit part of the study. It was mentioned in the beginning, and it's actually an inclusion criteria, that they only accepted patients in this study that were on one of 5 predetermined antibiotics, that actually excluded over 900 patients, which is more than how many patients were even included in the trial. That also puts limitation on some of our findings. Part of being in the study required in-person follow-ups between days 2 and 5, as well as 2 additional follow-ups between days 11 and 14 and 14 and 30. The way that this entire study is constructed will require you to go to those appointments, but then it also makes it possible to have follow up on those days. Sometimes, just with how inundated pediatricians can be, that might not be something that is actually generalizable outside of this clinical trial because you might not be able to get in to see your pediatrician that often. As far as the patients themselves, this is predominantly female inclusion in this study. Over 96% of patients were female, 64% were white, 91% were non Hispanic. From ages 2 to 6 years old, that almost accounted for about 60% of the population. Very few children were 2 months to 23 months of age. And then 87% of these patients were all treated with cephalosporins, even though there were some other selections in those 5 that aren't under that category. And then we hit on this earlier, over 32,000 patients were screened for this, but only 700 were enrolled. 20,000 of these patients were excluded due to negative urine cultures, and then another 4,300 for other reasons, which could potentially give some selection bias based on who's included and who's being treated. The investigators achieved much better failure rates than they initially had assumed. In a non-inferiority trial, inaccurate assumption of rates make it easier to find new treatment to meet the non-inferiority limit. One of the important things to consider is researchers excluded patients with missing data. Patients that were lost to follow-up are known to have worse outcomes than those who completed the study. So although seemingly a relatively small number, the 9 patients that were lost to follow-up in the standard course arm of therapy could potentially be 4.5 times larger than those who failed the treatment. Let's talk a little bit inside the numbers as far as intention to treat, numbers needed to treat, and then non-inferiority.
You mentioned earlier in the results, in the intention to treat analysis, the upper bound of the 95% confidence interval for treatment failure was 5.5%. And that exceeded the preset margin that they set at 5% for the non inferiority threshold. It's really important for us to highlight what an intention to treat analysis is looking for. So, intention to treat analysis includes all patients based on our original randomization, regardless if they adhere to study protocol or not. And generally, this provides a more cautious estimate of the treatment benefit. But let's say in a study, we hypothetically included a lot of non adherent patients in the control group. You could potentially give you a false interpretation of statistical non inferiority. On the SCOUT trial, the adherence was really good after randomization during days 6 to 10. But we really don't know anything about the patients during their initial 5-day treatment and how good the adherence was on those because they technically weren't in the study yet. If we look in a non inferiority trial, a per protocol analysis can often hold equal importance. This eliminates a lot of non adherent patients. And again, it's going to introduce some bias because it's going to mess up the randomization, but it can actually provide some reassurance that patients receive the appropriate treatment. If we look in the SCOUT trial, in the per protocol analysis, patients who adhere to at least 80% of their assigned therapy, the upper bound of the 95% confidence interval for treatment failure was only 3.9%, which was less than the 5% non inferiority margin. Let's talk about relative risk. The relative risk in this study was 6.8, and that indicates that patients who received 5 days of antibiotics were nearly 7 times more likely to have a treatment failure compared to 10-day therapy. But it's really important that we remain cautious when interpreting the relative risk because this can really exaggerate the magnitude of the impact. That's why looking at absolute risk difference is also important. And if we look at the absolute risk difference of 3.6, that indicates that just about 4 more patients out of 100 would experience a treatment failure with the short course therapy compared to the standard course 10-day therapy. It's up to clinicians and parents if 4 more patients is worth the expense, the burden to the healthcare system, the potential for adverse reactions.
Moving on to something that we had talked about earlier, there were 20,000 patients prescribed antibiotics that did not have a UTI. Some of the inclusion criteria were very non-specific findings. We talk about trace leukocyte esterase, on urine dipstick, fever. Although those are two of the three inclusion criterias, the third inclusion criteria was a positive culture. When we're seeing these patients, we don't have the ability to make that decision because it takes a couple of days for those cultures to grow out. That's a piece of information that we don't have in real time. Now, in order for research to be accurate on whether the treatment is or is not going to work, it's really important to make sure that you have a disease that goes along with the research. We don't have the luxury of knowing whether the culture is going to be positive or negative. So instead, it's almost like we're thinking in bets and making decisions on potentials and probabilities and then treating accordingly. A more pragmatic trial would be less stringent inclusion criteria and would include all the patients that we're treating for UTI, but then we're, again, presumably allowing patients with non-UTIs into the story. Although altering part of that inclusion criteria in the study would make it more practical, more appropriate for our practice, it's not always going to be helpful when it comes to the data.
I think that's a critical piece of information, and it really belies the fact of how difficult it is to diagnose these patients with urinary tract infection. These are young kids. Some of them may not be able to tell us what's bothering them, so we're relying on these clinical cues. And in fact, when we're treating for urinary tract infection and lots of other disease processes, like you said, I mean, you hit the nail on the head. We're not really doing it based on positive cultures and definitive tests, right? We're doing it based on probabilities and estimates and what we think is the best guess and shared decision making with parents. But when you look at the fact in here, I mean, we really can't overstate this, but 20,000 patients were excluded who did not have a positive urine culture. But those were 20,000 patients who were also treated with antibiotics for a urinary tract infection. And I would suspect that I've definitely never worked in a place that had the bandwidth to go back and call all those patients and say, hey, you don't need to take these antibiotics anymore. Your culture came back negative, right? So we're exposing all of these 20,000 patients to antibiotics that are not doing anything and potentially even harming them.
This is actually the second time you use the idea of shared decision making capacity. Why don't you touch a little bit more on that and interweave how this relates to both the study data as well as antibiotic stewardship that we're talking about?
Yeah, it's a great segue. As we said earlier in the results, the short course or 5-day therapy did not prove to be statistically non inferior to the standard course or 10 days of therapy. But what does it really mean to exceed this arbitrarily determined non inferiority margin of 5%? And we exceeded it by only 0.5%. And that means that one additional patient would experience a treatment failure in 200. Clinicians who are willing to accept 5 treatment failures per 100 patients, they might also be willing to accept 5.5. A 5.5% failure rate in patients diagnosed with UTI, that might be unacceptable for clinicians and some parents. But in the SCOUT trial, like we said, thousands of patients were prescribed antibiotics and they had negative urine cultures. So think about all the harms that we potentially might be doing by exposing these patients to antibiotics unnecessarily. Now, when we're making decisions with incomplete information, to me, short course antibiotics actually seem appropriate as long as shared decision making occurs concomitantly. If we're going to prescribe short course antibiotic therapy, we have to make sure that the parents understand, based on the best available evidence, there may be an increased likelihood of treatment failure, and they need close follow up to determine perhaps if they're not responding well enough or appropriately enough, their child may need a longer course of antibiotics.
I think that that sums up the bottom line for both the author's conclusion, our clinical bottom line. And if you are interested in reading both Marco's post as well as the article, go to rebelem.com and you can look up the SCOUT trial, short versus long course antibiotic use in pediatric UTIs. Marco, thank you so much for joining me today, and let's do it again soon.
Yeah, always a pleasure. Can't wait.
All right. Thanks, bud.